Welcome to NCLEXMap, your trusted source for mastering evidence-based cardiovascular pharmacology. In this session, we'll dive into the essential cardiovascular drug classes crucial for your clinical practice and NCLEX success. Each category reflects vital nursing judgment, grounded in safety, precision, and evidence. Let's get started with ACE inhibitors, like lisinopril. These medications block the conversion of angiotensin I to angiotensin II, leading to systemic vasodilation. They're indicated for hypertension, heart failure, and renal protection in diabetes. Watch out for a persistent dry cough, hyperkalemia, and hypotension as major side effects. Always monitor blood pressure and potassium levels closely. If you notice swelling of the face or tongue, notify the provider immediately. It could be angioedema. Next up, we have ARBs, such as losartan. These block angiotensin II receptors, promoting vasodilation without affecting bradykinin. They're great for hypertension and heart failure, but still carry a risk for hyperkalemia and hypotension. If a cough develops with ACE inhibitors, ARBs are the go-to alternative. Now, let's talk about beta blockers, like metoprolol. They reduce heart rate and contractility by blocking beta-adrenergic receptors. Indicated for hypertension and post-MI cardioprotection, they can cause bradycardia and fatigue. Always check the apical pulse for a full minute before administering. If the heart rate is below 60, hold the dose and notify the provider. Next, we have calcium channel blockers, like diltiazem and amlodipine. These inhibit calcium entry into cardiac cells, promoting vasodilation and reducing heart rate. They're used for hypertension and angina, but watch for peripheral edema and constipation. Avoid grapefruit juice, as it can increase the risk of toxicity. Let's move on to alpha-1 blockers, like prazosin. These block alpha-1 receptors, leading to vasodilation and reduced peripheral resistance. They are indicated for hypertension, but be cautious of first-dose orthostatic hypotension. Always advise patients to rise slowly to prevent falls. Now, onto alpha-2 agonists, like clonidine. These stimulate central receptors to decrease sympathetic outflow and lower blood pressure. They can cause sedation and dry mouth, so reinforce adherence to the regimen. Next, we have vasodilators, like nitroprusside and hydralazine. These directly relax vascular smooth muscle, lowering systemic vascular resistance. Nitroprusside is used in emergencies, while hydralazine is for chronic hypertension. Always monitor for side effects like reflex tachycardia and cyanide toxicity with nitroprusside. Let's discuss cardiac glycosides, like digoxin. These increase myocardial contractility and slow AV node conduction. They're indicated for heart failure and atrial fibrillation, but be cautious of toxicity risks. Always check the apical pulse and monitor potassium levels closely. Next, we have nitrates, like nitroglycerin. These convert to nitric oxide, reducing myocardial oxygen demand. They're used for angina, but watch for severe hypotension, especially with PDE5 inhibitors. Administer while the patient is sitting or lying down to prevent dizziness. Now, let's cover antiplatelets, like aspirin and clopidogrel. These inhibit platelet activation to prevent myocardial infarction and stroke. Monitor for bleeding and educate patients to avoid combining with other NSAIDs. Next, we have anticoagulants, like heparin and warfarin. Heparin is rapid-acting, while warfarin is long-term. Both require careful monitoring. Always check for bleeding and educate about consistent dietary vitamin K intake. Let's not forget thrombolytics, like alteplase. These dissolve existing clots and are critical in acute ischemic stroke. Monitor for signs of bleeding and perform baseline neurologic assessments. Finally, we have antihyperlipidemics, like statins. These lower LDL cholesterol and triglycerides, but watch for muscle pain and liver function. Always monitor liver enzymes and educate about the timing of administration. Now, let's summarize some key safety points. Hold beta blockers or digoxin if the apical pulse is below 60. Never combine nitrates with PDE5 inhibitors to avoid fatal hypotension. Maintain INR for warfarin and APTT for heparin within safe ranges. Monitor potassium closely with ACE inhibitors and ARBs. Educate every patient on medication adherence and early recognition of adverse effects. Every cardiovascular medication carries immense therapeutic power and responsibility. By integrating pharmacologic knowledge with nursing judgment, we ensure optimal patient safety. Continue to practice with clarity, evidence, and confidence. This is NCLEXMap, advancing nursing excellence through knowledge, precision, and purpose.